What is your name?
Acharya.
Okay, tell me your concern. Okay. So today we will perform CVS examination on you. Common and concerning symptoms of the heart include chest pain, palpitation, and shortness of breath. After hand hygiene, I am ready for physical examination. Jugular venous pressure examination is the first step in our cardiovascular assessment. JVP is best assessed from pulsation in the right internal jugular vein. I am adjusting a pillow under the patient's head to relax the sternocleidomastoid muscle and try to make 30-degree angle. I start my examination to watch both sides of the patient's neck and then turn the patient's head slightly to the left. Since the physical examination is conducted from the patient's right side, by focusing on the right side, I should identify the external jugular vein and then I have to find the internal jugular pulsation. Then I remove a pillow to see the oscillation point of the internal jugular venous pulsation in the lower half of the neck. Internal jugular pulsation are rarely palpable, whereas the carotid pulse almost always palpable. The level of internal jugular pressure falls with inspiration, whereas the carotid pulse is not affected by inspiration. Internal jugular pressure is eliminated by light pressure or vein just above clavicle, whereas the carotid pulse not affected by pressure. To starting my JVP examination, I took 3 by 5 card for horizontal line and ruler on the sternal angle and line it up with a vertical line. This measurement identifies the JVP. I take the measurement at the nearest centimeter in my patient. The JVP is about 2 cm above the sternal angle. The carotid pulse provides valuable information about valvular heart disease and is especially useful for detecting aortic stenosis or aortic insufficiency. My assessment will include both palpitation to assess the amplitude and contour of the carotid obstruct, auscultation for the presence or absence of bruise from turbulent blood flow, inspecting and palpating both right and left carotid artery, but I am aware to not press both carotid arteries at once since syncope may occur. Then I placed my index and middle finger on the right carotid artery. Then I slowly increase the pressure to feel the maximal pulsation and then slowly decrease pressure to detect arterial pressure wave and contour. I ask patient to hold breathing for a moment so that breath sound do not obscure the sound of turbulent flow. Wishing murmur like sound often occur in atherosclerosis disease. Heart examination. First, I inspect the anterior chest, noting any heaves and lifts. Then I proceed with palpating the chest wall. First, palpate for heaves or thrills using my finger pads. I hold them flat on the body surface, palpate in the right and left second interspace along the left sternal border and in the apical area. Ventricular impulses may heaves or left finger suggesting ventricular dilatation, which is not seen in here. Then I use my palm to check thrills by pressing the ball of my hand firmly on the chest in the same location. I have to identify the apical impulse. Apical impulse represent the brief pulsation of the left ventricular as it moves anteriorly during contraction and touches the chest wall. Palpate to confirm the characteristics of the apical impulse. In that I have to notice location, diameter and amplitude. Then I ask patient to tip on his left side. In the left lateral decubitus position, I palpate again using the palmar surface of several fingers. And measure the diameter of the impulse in centimeter to feel for the amplitude of the apical impulse. Next, I feel for the right ventricular impulse at the lower left sternal border while keeping on finger in the third interspace. Place additional fingertips in fourth and fifth interspace. Then I feel for the right ventricular impulse in the epigastric or subxiphoid area. Now I begin to hear your heartbeat over this area of your chest. I begin listening to the aortic area at the right second inner space close to the sternum. Starting in the right second interspace, try to identify S1 and S2. Aortic area, S2 is louder than S1, and in the pulmonic area, S2 is louder than S1. Please take a breath in and out. Still listening in the pulmonic area, try to identify the inspiratory splitting of S2 into two components. Its first component is A2, is from aortic valve closure, and its second component is P2, comes from the pulmonic valve closure. The physiologic split of S2A and S2P normally occur during inspiration, and during expiration, however, these two components are fused into single sound S2. Now I am listening lower left sternal border in the left fourth and fifth interspace. And then I try to listen at the apex. Can you please take over left side? Then I tell my patient to tip over to the left side. I placed the patient in the left lateral decubitus position to hear S3 and S4 and murmur of mitral stenosis. This position brings the left ventral closer to the chest wall and make low pitch sound more audible. The third heart sound will disappear with firm pressure, and the light pressure we will able to listen again. Heart murmurs are differentiated from heart sound by their longer duration. Palpating the carotid pulse can help us with timing. Murmurs are classified according to where they fall in systole and diastole. Palpating the carotid obstruct as we listen to the murmur is an important tip that helps us to decide if the murmur is systolic or diastolic. Systolic murmur can be early, mid, and late systolic or even pan-systolic. For detecting murmur, we should use two maneuvers. First maneuver is performed with patient sitting up and leaning forward. This maneuver enhances detection of aortic regurgitation by moving the left ventricle to the chest wall. I ask my patient to exhale completely and hold his breath. By using the diaphragm or stethoscope, I listen at the left second interspace. For the second maneuver, I tell my patient to tip over the left side. This helped me to detect the murmur of mitral stenosis. This position enhanced detection of the more subtle opening snap and diastolic rumble of mitral stenosis.